Approach to acid-base. The learning objectives for this lecture is number 1, to develop a reasonable approach to acid-base disorders, and secondly, to understand the concept of anion gap and delta gap, and explain their clinical applicability in helping us to determine the cause of a metabolic acidosis. A normal pH is around 7.4, and it is mainly determined by the proper balance between acid and bases. Since the body is very sensitive to small changes in pH, the maintenance of acid-base balance is strongly regulated. If the pH increases or falls outside of the acceptable range, this can have important repercussions at the molecular and cellular level and may even cause death. In our body, the most important regulators of this pH balance are several intracellular and extracellular buffers, but more importantly, the lungs and the kidneys. The lungs are the main regulators of carbon dioxide concentration, whereas the kidneys are involved in sodium bicarbonate absorption and excretion. Both CO2 and bicarbonate are the most important acid and base involved in determining blood pH, respectively. When approaching an acid-base disorder, there are important rules that will help you to be systematic. First, it is always important to keep in context the clinical picture and use the laboratory results to complement the clinical suspicion. In other words, if someone presents to the emergency room with persistent diarrhea, we should expect the labs to show, based on the clinical picture, a metabolic acidosis due to the loss of bicarbonate in the stools. The laboratory workup usually required for acid-base interpretation include a chemistry panel, arterial blood gas, and sometimes, as we will see later, it is also important to obtain a serum albumin. When approaching an acid-base, try to explain the disorder in the simplest term possible. Single acid-base disorders are more common than double or triple acid-base disorders. Also remember that a normal pH does not exclude an acid-base disorder, and sometimes a hint in this situation is the concomitant presence of an elevated anion gap. Finally, it is important to remember that the body never overcompensates a primary disorder. In other words, if you have a low bicarbonate suggesting a metabolic acidosis, but the pH is normal or elevated, this means that the primary problem is an alkalosis and not an overcompensation. I will describe here 5 steps in the approach to acid-base disorders. First, what is the pH? Second, what is the primary disturbance? Third, what is the compensation? Fourth, calculate the anion gap. And fifth, calculate the delta gap. If you systematically follow these steps, I can guarantee that you will excel anytime you approach an acid-base disorder. Step 1. What is the pH? A normal pH ranges between 7.35 and 7.45. But for simplification, let's assume that a normal pH is 7.4. The first thing you would like to know when approaching an acid-base disorder is, what is the pH? Anything below 7.4 is considered to be an acidosis. Anything above 7.4 is considered to be an alkalosis. Second, what is the primary disturbance? I already mentioned that the pH is mainly determined by changes in CO2, bicarbonate, or both. When the pH is low, this is due to either an accumulation of CO2 or loss of bicarbonate. When the pH is high, this is usually to a decrease in CO2 or accumulation of bicarbonate. After you commit to either acidosis or alkalosis, as I showed you in the step 1, then your second step is to look for the changes that will explain the abnormal pH. This is very important because most likely both CO2 and bicarbonate will be abnormal. That's why it's imperative that you know in advance which abnormality is the one that you will explain the pH that you have. And then look for it in labs. For example, if your pH is above 7.4, then you're looking for either an elevated bicarbonate or a decreased CO2. If your pH is below 7.4, then what you're looking for is either a decreased bicarbonate or increased CO2. After you find the abnormality that explains the change in pH, then you're ready to determine the primary disturbance. If the abnormal pH is due to a change in bicarbonate, then it is a metabolic problem. If the abnormal pH is explained by a change in CO2, then it is a respiratory problem. Step 3. Check for compensation. When there is a metabolic problem, the lungs usually compensate. When there is a respiratory problem, the kidneys are the ones that compensate. Here, there are different formulas we use for calculate compensation. The most commonly used is the Winter's formula. Essentially, this formula tells you that during metabolic acidosis, what is the expected pCO2 for any given bicarbonate. In other words, to assess the lung compensation during a metabolic acid disturbance. The expected CO2 should be 1.5 times the serum bicarbonate plus 8, within a range of plus minus 2. Step 4. Calculate the anion gap. In our body, everything is on homeostasis. For every positive charge particle or cation, there is a negative charge particle or anion in order to maintain electron neutrality. When we obtain a chemistry panel, we are able to measure the cations and anions present in the serum. The most important cation, for example, is sodium. The most important anions are chloride and bicarbonate. When you compare the amount of cations that we measure in serum with the amount of anions, you can appreciate that there is a mismatch, in other words, a gap. Because we know that this should be electron neutrality, then we can infer that this gap is due to the presence of anions in the serum that we normally do not measure, the so-called unmeasured anions. The anion gap is usually 12 plus minus 2, and this includes usually phosphates, sulfates, organic acids, and proteins, including albumin. In these two examples, there is a decrease in the concentration of serum bicarbonate, that by definition is a metabolic acidosis. In example A, the low bicarbonate is due to an accumulation of another anion. This is called elevated anion gap metabolic acidosis, in which case, if you calculate the anion gap, it will be obviously elevated. In example B, the metabolic acidosis is due to pure loss of bicarbonate, with associated increase in serum chloride. In this case, the anion gap is normal. This is called hyperchloremic or normal anion gap metabolic acidosis. Step 5. Calculate the delta gap. When we have anion gap metabolic acidosis only as a single disorder, the change in the anion gap should be equal to the change in the bicarbonate concentration. If, for example, the anion gap increases by 8, then if we are in the presence of a single metabolic acidosis, the bicarbonate should be also changed by 8. If the change in the anion gap is not the same as the change in the bicarbonate, then this means that there is another metabolic acid-base disturbance superimposed. For example, when the change of the anion gap is more than the change on serum bicarbonate, in other words, if the anion gap increased by 8 but the bicarb decreased less than 8, then this means that there is more bicarbonate than expected for the anion gap change. This usually means that there is a superimposed metabolic alkalosis. On the other hand, if the change in anion gap is less than the change in bicarbonate, let's say for example that the anion gap increased by 8, but the bicarbonate, instead of decreasing by 8, decreases even more, then this suggests that there is an extra loss of bicarbonate and a superimposed normal anion gap metabolic acidosis. Finally, this case will summarize what we just learned. A 32-year-old patient with a history of diabetes mellitus type 1 presents to the emergency department complaining of abdominal pain, nausea, and persistent hypoglycemia in the setting of running out of insulin 3 days ago. Initial laboratory workup is shown here. As you can see, he's hyperglycemic, hyperkalemic, and has an elevated creatinine. Clinical history suggests that he may have diabetic ketoacidosis and acute renal failure, which can explain a metabolic acidosis. Step 1. What is the pH? Since the pH is less than 7.4, this is by definition an acidosis. Step 2. What change will explain an acidosis? A pH of 7.3 can only be explained by either an elevated CO2 or a decreased bicarbonate. If we look at the CO2, it is not elevated, so this is not a respiratory problem. If we look at the bicarbonate, it is indeed decreased, suggesting this is a metabolic acidosis. Third step is the anion gap, and the calculated anion gap here is 22, so this is an elevated anion gap metabolic acidosis. Step 4, what is the compensation? Using Winter's formula, we see that for a bicarbonate of 6, the expected CO2 is 17 plus minus 2. In this case, the CO2 is 18, so there is an adequate compensation. And finally, step 5, what is the delta gap? We see that the anion gap increased from a normal of 12 to 22, so there's a change or delta of 10. It is expected then that the bicarb should decrease also by 10. In this case, you can appreciate that the bicarbonate changed more than the anion gap. Based on that, we can conclude that there should be a superimposed problem. The bicarb changed by 18 instead of changing only by 10. Since the bicarbonate is even lower than the expected, this also means that there is a superimposed normal anion gap metabolic acidosis. Final diagnosis is an elevated anion gap metabolic acidosis with a superimposed normal anion gap metabolic acidosis.